Bonjour, good morning, everyone. For the last clinical case of this edition of 𝗪𝗂𝗋, it's a pleasure to introduce you Gabriela Il with us with this amazing experience with DEBRICHEM. Gabriela.
Thank you, everyone. So I will talk today about my experience as an infectious disease specialist, but also a public health specialist, and I'm specialized in wound care. Why an infectious disease will try to heal some wounds? We will see why. We can see here by Lancet that the global burden of bacterial antimicrobial resistance will grow more and more. So I'm searching techniques to fight biofilm without using antibiotics. And also antibiotics don't work on the bacteria who are in the biofilm. So what's happening? If we are seeing what's happened for the mortality between these, no? Ça se voit pas. Sorry. We can see here that the mortality due to superbugs is increasing with the time, and all the patients who has more than 50 years will have this mortality increasing. When we are looking at 2021, we can see that the superbugs are around the world, but it's not so hot, not a lot of hot spots. But if everything will go on like now, without new antibiotics or with the use of too much antibiotics when not needed, this is what will happen. And what we are seeing here, these hot spots, if everything goes like now. You must know if you have a war, the war will go with migration, with a lot of public health systems, and we can have even more deaths than we can see here on this slide. So what are the bacteria who are concerned by this mortality? We can see 𝗪𝗁𝗃 coli will grow and grow. This is urinary infections mostly, but we can see also 𝗪𝗀𝗃𝗄𝗃 aureus. It's also with higher rate of mortality. And the people who are concerned are people who are my age today. So we are the people who will have 70 years old in 2050. Also, there's a medical and economic burden and challenges in wound care. In France, in our national congress at Paris this year, we can see that we have more than 2.5 million people who suffer from chronic wounds, and we have a lot of pressure sore, a lot of diabetics who will have diabetic foot wounds, and with the epidemiology of obesity, this will increase every year. And the cost of the healthcare only in France is more than 1 billion a year. And in Europe, you can see here that 4% of healthcare cost is due to wounds. So what can we do? We have elderly people with a lot of chronic and hard to heal wounds, and we must fight against infection. When you have a wound, this wound will go by 6 stages. In the first of the acute wound, you will have a contamination with natural skin bacterial, but there are no problem for the wound to heal. And if you are not doing anything, you will have a colonization. And what's interesting that by time you will have more and more bacterial in number, but also by the diversity of our species. So when you are at the stage of local wound infection that can be subtle or even classic that we know with all the purulent discharge, with local worm, with wound breakdown, but also increasing malodor and new pain, then we can act against this with debridement, with different type of debridement. Of course, if we are doing nothing, the sepsis will come with this wound who will grow and who will be increasing in size. But there, the problem is not the wound. You will have to take care of your patient because he will have a sepsis and he can die. And the wound will go worse and worse, inevitably. So what you must do is use debridement. You have different type of debridement, and here I will speak about chemical debridement with DEBRICHEM. You must not do any swabs. We know that we have a lot of bacteria on this wound, and we don't want to treat very hard to treat bacteria like Pseudomonas who are on the biofilm, but they are not. They will not induce, in most cases, any infection. So, how do I treat a wound? I don't treat only by debridement. I don't treat only by antibiotics. My strategy is treat the colonization of or infection, then protect it with negative pressure wound therapy, revigorate your wound, but also calm the pain with skin grafting that you can protect and secure again with a negative pressure wound therapy, and the wound will be healed, I hope. So, when you are at the third or fourth stage of local wound infection, you can use chemical debridement. Why? It's one single application, 1 minute. You will rinse. And after that, you will have a layer of carbonization. This layer of carbonization, it's sterile. I did for my patient in the beginning some swabs before DEBRICHEM and after DEBRICHEM. And the culture after DEBRICHEM was sterile. And in my wounds, I had initially 3 or 4 bacteria, and even Staphylococcus aureus medicine resistant. So it's working in all bacteria. Why? Because it's breaking all your molecule of water who are in your biofilm, but also in your bacteria. So it's working, and even in the worst bacteria. This is only a moment in your wound strategy, because what is important when you have this type of wound, then you can revigorate and do after 10 or 14 days skin graft. You have the choice. You don't have to do mesh skin graft who needs a sterile environment. You can do it at in the room of the patient, like you can see in the first picture, and you don't need a lot of costly material. You need only a punch that are used normally to do some skin biopsy. After that, you put it on your wound, and you can secure, like in the third photo, with a negative pressure wound therapy, who also will go protect your wounds who was treated initially. And you can see here on the second image that you don't have a lot of material. So here you can see the case in old woman who has a lot of cardiovascular comorbidity, and she had this chronic wound for more than 1 year and a half. We did a chemical debridement. In the first photo, you can see the wound before the chemical debridement. You can see the action of the DEBRICHEM on the wound, but also 1 centimeter around your wound, because you have biofilm who will not stop only on your bed of the wound. And you can see the layer of carbonization in the third photo. 10 days after, this layer of carbonization can be removed naturally without forcing it, and we can do skin grafts with negative pressure wound therapy. But this patient is very old. She has blood flow in her legs who's not so good. So sometimes to treat this patient, you need more techniques. So DEBRICHEM and chemical debridement, it's something that you will use in a sequence of treatment in these hard to heal people. no one will go treat the arteriopathy of this patient. He's very old, and you can see that her heart is not going very well. So the anesthesiast didn't want to do the general anesthesia for her. So what we can do, we can stimulate the wound, but also the perilesional skin. And here that was with laser, RecoSMA and erbium. And after 10 seconds, we can see that we have now, I'm sorry, it's not working. We can see now that the wound is ready for another skin graft. And when you see the first one, you didn't have anything, no granulation. That was a ton that was not moving for 1.5 years. And you can see in the last one that we have already a start of epithelialization on the wound. So another young patient who has also hypertension, an arterial insufficiency lower limb with partial revascularization, but also a debridement, a surgical debridement of the necrosis. But we see that the necrosis is going on because you will have here, if you are seeing a little bit of purple color around the wound, it's that you have angiodermatitis necrositis. So if you are going to challenge by mechanical debridement, this wound will continue to grow. So what we tried here in this patient is that we make some analgesic cream. This is why you have the film there, because it's in an acid, so it burns. And after that, without any pain, we put DEBRICHEM, and we have the layer of carbonization in the second image. So in this kind of wound, it's difficult to follow, to know if your size is diminishing. So we use a different application, like you can see here, to have the exact size and to have also the percentage of granulation or necrosis or fibrin. So it's important. So what's happening after that? So we did also a skin grafting in pellets. You can see that the size of the wound is very large. We didn't do any mesh skin graft because we had mostly fibrin of 50%. So we did, for stimulation, skin graft by pellets. It's very easy, like you see it. We had used different types of negative pressure wound therapy. These are little devices who create for the patient a quality of life because this patient can walk. And it is important with his lower limb insufficiency on arterial flow that he is walking. So we can see here the results after 2 weeks. So today, he has always this wound, but the size of the wound is the half before we treated this patient. So did he have some antibiotics? Yes, he has oral antibiotics, but not for the biofilm and the wound that you see. He came to me without fever, but with a lymphangitis. And my nurse did a swab, and there was Pseudomonas aeruginosa. Amoxicillin acetylcholic doesn't work on Pseudomonas aeruginosa, but we can heal the infection because the infection was really did by streptococcal, like mostly. So that was enough. 7 days only of antibiotics, but not for the wound, but for the complication, local regional complication of this wound. So the importance of chemical debridement also in other atypical wounds where you have a lot of pain and you can't do any instrumental debridement. So here we can see 2 images with calcification in the wound. And if we are doing a standard radiography, we can see a lot of calcification. Is this a calciphylaxis? So you can't make any diagnosis on the wound clinical wound and on your radiography, because you can have this type of sign in every old patient. This is not calciphylaxis. To have the calciphylaxis, the diagnosis for this wound, you must take a very profound biopsy. So my punch biopsy, it's not enough to go and have your little arterial who are ischemic in the wound with calcification. But this is a calciphylaxis, but not with these signs, okay? So this patient had a stroke and hemiplegia, but also she could walk with a walker. He has hypertension, he has also a pacemaker and a vitamin K antagonist, who is a factor of risk for calciphylaxis. And we see the persistency of this wound for more than a year on the right leg, so painful and with a lot of inflammatory around the wound, and the mechanical debridement was impossible. So the general practitioner did a treatment by amoxicillin aciclovulanic, but there was no difference, nor in the pain or in the situation, clinical situation of the wounds. And the patient couldn't walk anymore because the pain was high. The treatment by opioid wasn't well tolerated, and we don't have a lot of active scanner. It's a little dose, but she couldn't support that. So we decided to treat this patient with chemical debridement. You can see the first picture and the second 1 minute after the application. You can see this carbonization of the wound. So here we treat the infection and we will protect here with a negative pressure wound therapy. It's not only protection, but this will increase your blood flow in your little capillary, and all the exudate will go into this dressing, which is not a real dressing. So what's happening after that? After that, we can wait and do normal dressings, but I can't wait. I want to go quicker because these are patients who were suffering for pain for months, for years. So everything is important for them to see that you can go quicker. So we did a skin graft in pellets, even if our wound wasn't so lovely like dermatologist like. We did a negative pressure wound therapy associated, and we can see that at day 10, after the skin grafting, you can see vascularization of your little grafts, but also your wound is little. You have already an epithelialization on your wound. And we could stop opioids, and our patient could walk again. So if you want to see more information, we did a series of 20 patients with a high level of comorbidities. So they are patients who will never go into very lovely prospective trial because they have all these comorbidities, and it's complicated for us. But you can see the treatment in real life of these 20 patients. So what's going on? We had amputation because all of these patients had arterial blood flow complication. But we have also revascularization with wound healing. So you have a little bit of amputation for the patients, but we have patients with great results, and we were thinking that there was a palliative stage, and we had good results for this. You can see that you can have the epithermization who are growing. It's not perfect, but the patients are real life patients, not perfect, neither. And you can have a 50% of granulation. And when you have granulation, you can do other technique like skin grafting. Here, a patient who was at a palliative stage, who has already an amputation, and he was prepared already for a new amputation in transfemoral in this leg. So already he has an infection of the bone. He had 6 weeks of treatment, antibiotic treatment, after a bone biopsy with great doses. But this wasn't healing. The bone was healed, but not the wound, because the blood flow wasn't great, and the surgeon couldn't do anything but to propose another amputation and higher on your leg. So we can see in the first image that we have necrosis, that we have a lot of inflammation, fibrin. In the second, you can see the product who is already working with this layer of carbonization. And in the third picture, you can see the wound who is a little bit larger than after you apply the DEBRICHEM, because you have a lot of tissue who for you it's normal when you are seeing it, but on a cellular basis it's not viable. This is why you can have 2-3 millimeters more higher size of the wound. And we did negative pressure wounds therapy, and we can see here a great result, and the patient don't have amputation. And the patient can have now skin graft. And here, my team and a patient who has it's not the same patient, but this patient, we had 2 weeks to save his leg, and he didn't have any amputation. So I promised him that he'll come with me at Barcelona. Thank you very much. Some questions?
Do you always use after DEBRICHEM the negative therapy?
You don't have to use it, but I like to use sometimes this type of single-use negative therapy, or a larger one. You have the size of your wound. We have size of the wounds who is more than 2,000. It's very big, and if you can use it, yes. But you can do only simple dressing if you can, and your patient can go home. You don't need anything costly after DEBRICHEM, and the granulation will go on smoothly. And you can do also in a younger patient, you don't need to do everything like that. Here these cases are desperate for me, you know. They have, when you are going to look the poster, you can see that I have wounds from 7 years, never healed, you know. So I use this product in such of cases that are not recommended, okay? But I go for this patient because you don't have anything left for them. And when I have positive results, even if our complete percentage is not wow, it's great what I can have on these wounds. And the poster, I will present it at 1 o'clock on screen 3 if you want to see other cases if you want. Yes, at 1 o'clock on screen 3. Other questions? No? Thank you very much, and have a lovely Congress.